Afternoon. At this moment, we'll discuss a talk titled Clinical Symptoms and Science in Neurotology. This talk is basically for the general neurologists who are new to the neurotology practice and even for the general physicians. You can access more videos of otoneurologic practice. Subscribe to my channel that is shown here on this slide. The first slide is that do we need to inquire in depth when a patient complains I'm dizzy, मुझे चक्कर आ रहे हैं? The short answer is yes, because patients suffering from at least 7 different conditions which are as under may also say चक्कर आ रहे हैं. Orthostatic hypotension, diplopia, ataxia, acute confusional state. Here the patient's attendants say that इसको चक्कर आ रहे हैं. Epileptic fit, इसको चक्कर आ गए थे. Lightheadedness and syncope. So it is always important to dissect the symptom. What do you mean by chakkar? Definition of vertigo. Traditionally, it is the sensation of spinning of while the body is stationary with respect to the surroundings. The American Academy of Otolaryngology, Head, Neck and Surgery in 1995 defines the sensation of motion when no motion is occurring relative to the Earth's gravity. However, 14 years later, the Barani Society made certain common vestibular symptoms as determined by the international consensus. These are number one, vertigo, the sensation of self motion when no self motion is occurring, or sensation of distorted self motion during an otherwise normal head movement. They have been divided into 4 trigger types: positional, head motion induced, visually induced, sound induced. The dizziness is defined as sensation of disturbed or altered spatial orientation without feeling of false motion. And 3 subtypes are Valsalva induced, orthostatic, and other triggered forms. There are also vestibulovisual symptoms. This result from vestibular dysfunction or interaction of the visual vestibular systems. The examples include visual illusions of tilt, blurring of visual lag during head movements characterized as external vertigo, and 5 different subtypes, that is the external vertigo, oscillopsia, visual lag, visual tilt, and movement induced blur, have been subdivided and defined. The last is postural symptoms. These are the balance related symptoms that occur when upright, that is, in sitting, standing, or walking positions. Examples include feeling steady, swaying, rocking only when upright. And again, 4 subtypes are identified: unsteadiness, directional pulsion, that is the ipsy-pulsion that you see in the Wallenberg syndrome, balance related near fall, and balance related fall. So, with this in background, the vestibular symptoms defined by the Barani Society, in my practice, I usually start with these 17 questions when a patient complains that doctor, I am dizzy. Chakkar means what? Are you the surrounding objects spinning, feeling like oneself is spinning? If anything is felt as in 2 or 3 above, then what? Do you feel dizzy while lying down, getting up, turning in the bed, looking upwards, and bending forwards? That get clues to a important condition of BPPV. This is one of the most common treatable bedside condition. Do you get dizzy just on head motion? That occurs in almost always with a patient with true vertigo. Do you feel dizzy when you see nearby objects or people moving or shaking? That is a common thing in vestibular migraine. Do you stagger while standing or walking in a way that people around you can also notice it? Do you feel fear of falling while standing or walking? Do you lose balance while walking and fall to the ground or come close to falling? Do the surrounding objects appear tilted to you? Do you lean to one side while standing or walking? Has your hearing started to deteriorate? Do you expect buzzing, ringing, or any additional sounds in the ear? Do you also get headache along with the dizziness? Do you experience intense dizziness immediately upon hearing loud sounds. That could be because of perilymphatic fistula or superior semicircular canal dehiscence syndrome. So, after these 17 questions, you come to know roughly what this patient is suffering from. Then comes the duration of individual vertigo attack and the pattern recognition. Basically, you have three patients in emergency who come to you. One is acute monophasic illness, occurs acute vertigo, acutely dizzy, then they improve over a period of few days. The examples are acute labyrinthitis, that is vestibular neuritis, which is now called acute unilateral vestibulopathy, stroke, particularly in posterior circulation, psychogenic, that is paroxysmal non-epileptic attacks, and very rarely the true seizures, the tornado epilepsy may also come into emergency. The second is a person with remitting and relapsing course but with progressive deterioration. The classical examples are Meniere's disease, second is multiple sclerosis and TIAs. Very rarely, the patients with chronic imbalance, they out of frustration come to emergency. They have a progressive deterioration. The conditions they include acoustic neuroma, brain tumor, cerebellar degeneration, and hereditary ataxias. Mostly these patients with conditions C and D, they come for relief of symptoms they suffer from balance related fall or headache, especially in condition B. So the duration of vertigo, it is seconds to minutes in vestibular paroxysmia, BPPV, perilymphatic fistula, minutes to hours in posterior circulation, TIA and vestibular migraine. It is hours, nearly 20 minutes to 12 hours mostly in Meniere's disease, sometimes up to 24 hours, and days to weeks in vestibular neuritis, posterior circulation stroke. So that is important thing to ask about the duration of individual attack of vertigo. Basically, four types of presentations and seven common disorders occur. Acute vestibular syndrome is either acute vestibular neuritis or a stroke, cerebellar or brainstem infarction. That is 10% of acute vertigo cases. The second is recurrent positional vertigo. The three common causes are BPPV, central positional vertigo, and vestibular migraine. Remember here that vestibular migraine is also a cause of central positional vertigo. Chronic imbalance is bilateral vestibular loss, cerebellar ataxias, mainly heredidodegeneratives, and paraneoplastic. Recurrent spontaneous vertigo is either Meniere's disease or vestibular migraine. Again, it is important historically to come to a conclusion from the history from peripheral versus central vertigo. Nausea is mild to moderate in central, it is severe in peripheral vertigo. Imbalance is moderate to severe in central vertigo, it is moderate in peripheral vertigo. Hearing loss is rare in central vertigo but common in peripheral vertigo. But there is a rider here. If a patient with acute vestibular syndrome has a hearing deficit that you can demonstrate in the emergency department, he is likely to be suffering from acute stroke in posterior circulation. The symptom of tinnitus is rare in central vertigo, but it may occur in peripheral vertigo. Oscillopsia, which is a visual disturbance in which the patient objects in the visual field appear to oscillate, is severe in central vertigo. It's mild in peripheral vertigo. Neurologic signs are common in central vertigo. They are rare in peripheral vertigo. Compensation is slow in central vertigo because the compensatory factory is at fault. It is rapid in peripheral vertigo. Nystagmus, I have dedicated a full slide to it because this is one of the objective findings. Pure vertical, pure torsional, periodic alternating, multidirectional, disconjugate, that is conversion, retraction, nystagmus, or dissociated may change direction with gaze. That is gaze evoke nystagmus. On right gaze it is right beating and left gaze it is left beating is central nystagmus. The peripheral nystagmus is torsional, horizontal, unidirectional in all gazes and is conjugated. The visual suppression has hardly any effect on central nystagmus while it is suppressed it suppresses the peripheral nystagmus. Alexander's law is not obeyed in the central nystagmus. This states that the amplitude of the nystagmus increases when the eye moves in the direction of the fast phase, while it is obeyed in the peripheral vertigo. Direction fixed, central is not there, the peripheral is direction fixed. The localization, the structures involved in the central nystagmus is medulla, pontine tegmentum, cerebellum, while for the peripheral it is the labyrinth or vestibular nerve. We start with some examples. The BPPV comes with the positionally triggered disease pulse when the head move relative to the gravity. The typical right posterior semicircular canalolithiasis, it forms around 70% of the cases, and if you know this, how to treat it and diagnose it, your 70% of the work is done as far as the BPPV is concerned. A lady 38-year-old came with a history of positionally triggered disease spells for one day as she got out in the morning. The right Dix-Hallpike test shows right torsional upbeating positional nystagmus of less than a minute duration. So what to do next? The right Dix-Hallpike test was done, and after that right apply was done. Position 1, position 2, and finally the position 3, each of 1 minute duration. The patient was called next day for positional retesting. The verifying right Dix-Hallpike test, or you can say the right Dix-Hallpike retest, did not elicit any nystagmus. Patient's eyes are absolutely static and there is no concomitant vertigo. She continues to remain vertigo free. It is almost 6 years now. There is another thing which is called half Dix-Hallpike test, in which instead of carrying the head from the upright sitting position to 120 degrees at the head end in the head hanging position, the head is carried only around 30 degrees, 60 degrees. So how it can be done? Here I am demonstrating it. Usual in whom I am going to demonstrate the half Dix-Hallpike testing. This is a pillow, the width of which is around 4 to 5 inches. So first I am going to do a Dix-Hallpike test in the usual manner. The head is rotated 45 degrees to the patient's right, and patient is taken in the head hanging position. The head is around 30 degrees below the horizon. This position is being maintained for around 1 minute, exact 1 minute. When 1 minute is completed in the Dix-Hallpike, in this case right Dix-Hallpike head hanging position, the head is flexed 60 degrees so that it comes 30 degrees above the horizon. So this is called the half Dix-Hallpike testing, and we observe again for around half to 1 minute in this position. And if you see a beating torsional nystagmus which was not present in the head hanging Dix-Hallpike position, it could be either right sided posterior semicircular cubiculolithiasis or right short arm posterior semicircular canalolithiasis. Anyway, this is one of the methods, one of the 3 methods of doing the half Dix-Hallpike test. The other method is that we place the pillow like that, rotate the head 45 degrees to the patient's right, and now his occiput would land on this pillow which is 4 to 5 inches thick, and it will get anti-flexed 30 degrees आंखें खोलो and we observe for the nystagmus for at least 1 minute. This is one of the two methods. This is second of the two methods which is done. Again, the observation for nystagmus is around 1 minute. The third method is while doing the supine load test. When we do the supine load test, the first transition is sitting to supine with straight ahead. Now head you up to the 90 degree. Instead of that we do it 45 degrees, and that makes a आंखें खोल के रखो half Dix-Hallpike test. So these are three methods of doing the half Dix-Hallpike test, depending on how you start to do the positional test. If you start with the Dix-Hallpike test, then it is always better to wait for 1 minute and then anti-flex the neck 60 degrees. If you start with the supine load test, you can do the way I am doing right now. Thank you very much. There was an article by Dario Scocco in 2022. According to Scocco, in posterior semicircular cupulolithiasis, the oculomotor responses during the Dix-Hallpike test depend on the shape of the posterior cupula and the acting gravitational vector, which I have tried to show you by this diagram. This is the cupula, which is neutral cupula. During the Dix-Hallpike testing, the long axis of this right posterior cupula, it remains parallel to the Earth's gravity, and there is no deflection during the right Dix-Hallpike test. If there is a cupula which is canal angulated, that during the right Dix-Hallpike testing deflects ampulopetally. So the resultant nystagmus, which is left torsional and downbeating, would occur, and that would persist for more than 60 seconds. A cupula which is vestibular angulated, as you see here, during the right Dix-Hallpike test would result in persistent right torsional upbeating nystagmus lasting more than 60 seconds. So the optimal positional test for evaluating positional nystagmus in posterior semicircular cupulolithiasis and short-arm posterior semicircular canalolithiasis is the half Dix-Hallpike test coupled with inversion test. This is a landmark paper of year 2001 by the legendary John Apley from the Oregon, Portland. What did he say in this paper of 2001, 25 years ago? He said that there is a cupulolithiasis of adherent type and there is a cupulolithiasis of non-adherent type. And he talked of a half Dix-Hallpike test even during that time. So the diagnostic maneuvers and repositioning in short arm posterior semicircular canal BPPV. As you see here, the posterior cupula is parallel to the Earth's gravity during the Dix-Hallpike testing, and there is no positional nystagmus here. During the half Dix-Hallpike testing, the cupula becomes orthogonal, and in posterior cupulolithiasis as well as short-arm posterior semicircular canalolithiasis, there is a upbeating ipsitorsional nystagmus. This is the landmark paper that I was talking about. What did he say about that? Each cupula has two potential provocative positions oriented 180 degree to each other. Earthward deflection in one position is stimulatory and in the other position inhibitory. If particles are adherent to the cupula, persistent nystagmus will occur in both positions in the same plane, but reverse direction when the head is turned through 180 degrees. Identification of this nystagmus reversal with head inversion confirms the presence of cupulolithiasis. If the persistent nystagmus maximizes in one provocative position but does not occur in the inverse position, it suggests that cupulolithiasis may be present due to non-adherent particles falling away from the cupula in one of the position, but in that case, the diagnosis is less certain. So these uncertainties they remained there for another 22 years when in 2022 Dariuscoco came with this publication in which he published the sitting of vertigo as an expression of posterior semicircular canal, heavy cupula and posterior semicircular canal, short arm posterior semicircular canalithesis, and he found that the two can be differentiated on the basis of the inversion test. So why inversion test is positive during the half Dix-Hallpike maneuver in the posterior semicircular cupulolithiasis? This is the half Dix-Hallpike test. As you see here, the cupula is loaded on this side and there would be ampulofugal deflection leading to upbeating left dorsal nystagmus. As the patient is positioned right lateral recumbent with nose down, the cupula of the left canal, it starts deflecting ampulopetally, that is in an inhibitory direction, so that the nystagmus becomes downbeating and right torsional. This is shown here in this video. Full video I am going to show. The left Dix-Hallpike test is being done by placing a 4-inch thick pillow so that the 45-degree left yard head, it gets anti-flex at it as it lands on the pillow, and there you see a nystagmus which is upbeating. The torsional component, the upper corneal poles of both eyes are torsionally beating towards the patient's left ear. So it can be called a persistent left torsional upbeating positional nystagmus during the left Dix-Hallpike, half Dix-Hallpike testing. So once the critical point of 1 minute has passed, the next thing to be done is the inversion test, which in this case would mean positioning the patient right lateral recumbent with nose down and look for the inversion of the nystagmus. If the nystagmus that you see right now, that is the left torsional upbeating, becomes right torsional and downbeating in the inversion position that has occurred now, this means left posterior semicircular cupulolithiasis. And indeed you see inversion of the nystagmus. The nystagmus is now downbeating and with the upper corneal poles are torsionally beating towards the patient's right ear. So we have diagnosed the left posterior semicircular cupulolithiasis on the basis of carrying out a half Dix-Hallpike test coupled with an inversion test. Why inversion test is negative during the half Hallpike maneuver in short arm posterior semicircular canalolithiasis? So this is this long sitting position. This is the half Dix-Hallpike position. Here the otoconal debris is resting. It is not adherent on the short arm side of the left posterior cupula. So it would cause a stimulatory, that is excitatory left torsional upbeating nystagmus of more than a minute duration. But as the patient is transitioned right lateral recumbent with nose down, the otoconia, they fall away and there is no cupullar deflection, so that in the inversion position the nystagmus, which was persistent left torsional upbeating in the left Dix-Hallpike test, becomes the downbeating. Here it is not right, it is left, and this is being shown here in this video. The full video I am going to show here. The first thing about this video is that the nystagmus, it begins after a latency of 45 seconds, which itself is very unusual for the nystagmus of posterior cupulolithiasis, even if it is persistent. I am fast forwarding it to 41 seconds, and after 4 seconds you will see a nystagmus which is upbeating and left torsional. As soon as it reaches the critical threshold period of 60 seconds, the next thing to be done is a inversion test, that is transitioning her to right lateral recumbent with nose down, and look for the inversion of the nystagmus or the disappearance of the nystagmus. Inversion would mean left posterior semicircular kipulolithiasis, as we saw in the previous patient, and disappearance would mean left short arm posterior semicircular canalolithiasis. So this nystagmus is persistent. So next thing to do is a inversion test that will be carried out and will be illustrated here. Right lateral recumbent with nose down and looking the oculomotor responses. The nystagmus disappears. So we diagnose this patient as left short arm posterior semicircular canalolithiasis. We cannot take one or two downbeats as a evidence of left posterior semicircular cupulolithiasis, because in cupulolithiasis even the persistent nystagmus should last for a considerable time. We come to the horizontal canal BPPV. This is slightly difficult to lateralize. Why? There are two varieties. One is the geotropic, the supine roll test, which is also called the Hadio test or the Paganini-Macquer maneuver, elicits horizontal bidirectional nystagmus, that is during the Hadio to the left as well as to Hadio to the right, elicits identical nystagmus, which could be either geotropic with the quick component beating towards the lowermost ear during Hadio to right and left, or apogeotropic where the quick component beats away from the lowermost ear. So in the geotropic horizontal positional nystagmus, I have shown this by animation. The geotropic means the quick component of the nystagmus beats towards the lowermost ear on Hadio to left as well as right. This is right shown here, quick and slow. So in the geotropic variant, the involved site, that is lateralization, is one with the stronger positioning nystagmus during the supine roll test. That is, if it is more strong on right, the it would be a right-sided horizontal semicircular canal BPPV. In the apogeotropic variant, the quick component of the nystagmus beats away from the lowermost ear being tested, and it is if it is apogeotropic, it would be apogeotropic on both sides. Here, the lateralization is to the side with weaker positioning nystagmus during the supine roll test, either on right or to the left. This is the bow and lean test. Here, it is also called the head pitch test. The head is at first extended, the cervical spine is extended around 45 degrees backwards, and we look for a horizontal nystagmus. This is a test of secondary lateralizing importance in horizontal canal BPPV. Here you see a leaning nystagmus directed to the patient's right. In some of the countries like Italy, they rely heavily on the upright positional testing because of their strategy of minimal stimulus strategy. So now bowing the head, we do a maximum neck flexion and even the trunk flexion to make it around 90 degrees combined cervical spine and truncal flexion. And here the nystagmus is horizontal left directed. So it is important to remember here that in the geotropic variant of the horizontal canal BPPV, the direction of the bowing nystagmus is towards the involved side and of the leaning nystagmus is towards the non-involved side, while the opposite holds true for the apogeotropic variant. So if in this case, if there is a stronger, if there is a geotropic variant, then we can expect that the head yaw to the left would be stronger than head yaw to the right. So as I told you, geotropic horizontal semicircular canal BPP, bone nystagmus is directed to the affected side, lean nystagmus is directed to the unaffected side, away from the affected side. In apogeotropic horizontal canal BPPV, lean nystagmus is directed towards the affected side and bone nystagmus is directed away from the affected side. So this is the supine roll test of the patient in which we did a head pitch test, and as I said, if it is a geotropic, it would be a left sided. There is a lying down nystagmus to the right, and this is in concordance with the leaning nystagmus that we did 2 slides before. The direction of the leaning nystagmus and lying down nystagmus, which is also called situ supine nystagmus in some countries, has to be same. And if I do a supine roll test, that is head yaw to right or left, I expect a stronger nystagmus on head yaw to the left. This looks quite strong here on head yaw to the right, but let us compare it to the head yaw on the left. On head yaw to the left, there is even a stronger geotropic horizontal positional nystagmus, and this is in concordance with the test results of leaning nystagmus and the lying down nystagmus, which was beating towards the patient's right. So we have diagnosed this as left horizontal semicircular canal BPPV due to canalolithiasis in its long posterior non-ampullary arm that needs to be treated by the Guffoni maneuver for the left horizontal semicircular canal. This is another recent development. This is in fact called the roll movement. That when our head moves in such a way that the ear starts to come near the shoulder, this is called the roll movement of the head. So the head roll to the right initially did not elicit an nystagmus. This is again a strategy which is used in Italy as the minimal stimulus strategy. We don't see an nystagmus at first go. That sometimes even occur during the supine head yaw test. Then we did a head roll to the left in the upright position, and there you see a geotropic horizontal positional nystagmus. The quick component is beating towards the lowermost left ear. I repeated the head roll to the right, and now I could see a geotropic horizontal nystagmus that was not elicited on the first occasion. If this device is connected to a video nystagmogram generating the graphs, you can make out from the velocity which side is involved. But I believe more in visualizing it than believing on the graphs which are generated. So I did a bow and lean test also, tried to do, but nothing could be found unusual in that. So this is a 18-year-old patient, came with a history of vertigo for past 2 days. Even in 18-year-old patients, you can see on during the right head yaw, there is a geotropic nystagmus, quick component beating towards the lowermost right ear. On head yaw to the left, there is a even stronger geotropic horizontal positional nystagmus with the quick component beating towards the lowermost left ear, and this is clear cut a literalized case of geotropic left horizontal semicircular canal BPPV. What did we do with this patient? The Guffoni maneuver. From short sitting, the patient is briskly transitioned right lateral recumbent for 2 minutes, and then the nose was down. This is around 90 degrees, only 45 degrees is just essential. When we do a maneuver, this is the maneuver for the left geotropic horizontal semicircular canal BPPV, which is called the Guffoni maneuver. You need to do a supine roll retest also after 1 hour. That's I follow after 1 hour and at 24 hours. The left head yaw did not elicit any nystagmus, and the right head yaw did not elicit any nystagmus. Patient totally asymptomatic, and he continues to remain asymptomatic. Almost 6 years have passed now. This is otoconal debris in the long posterior arm of the left posterior horizontal semicircular canal. As the patient is taken to the right lateral recumbent, that is the non-involved side, the canal becomes vertical and the otoconal debris moves towards the vestibule. As the head is yawed 45 degrees to the ground, the otoconia enter into the canal, and on uprighting, the canal is free of the otoconal debris. There is also the apogeotropic variant of the posterior semicircular canal BPPV. This is a lady around 43-year-old, came in 2019. Supine roll test on head yaw to right, at least the supine sit to supine position should be maintained for 30 seconds. I could not see any lying down nystagmus. So head yaw to the right elicited a apogeotropic horizontal positional nystagmus. The quick component of this horizontal nystagmus is beating away from the lowermost right ear, and that's why it is called apogeotropic. The term apogeotropic and geotropic have come from the roots and shoots of the plants. The roots of the plant, they grow away, they grow towards the earth, that is called geotropic or positive geotropism, while the shoots, they grow away from the earth, that is called negative geotropism. In this case, we can say apogeotropic. So the quick component of the nystagmus is beating away from the earth, and it is now persistent. This nystagmus persisted for around 3 minutes. Fast forwarding it, at 2.5 minutes is still present. It is still present at 3 minutes and 21 seconds. On head yaw to the left, we can see that there is a apogeotropic horizontal nystagmus, that is the direction has reversed, but it remains apogeotropic. The quick component of the nystagmus is beating away from the lowermost left ear. And compared to the nystagmus apogeotropic type elicited on head yaw to the right, this nystagmus on head yaw to the left is the weaker one, and therefore the lateralization is to the left side, possibly left horizontal semicircular cupulolithiasis. Whether it is on the canal side or in the cupular side, we cannot make out right now. During that time, in 2019, the Zuma maneuver invented by Zuma e Maia from Brazil was not very famous. So what did I do to treat this patient? Anti-flexed her head around 30 degrees and high frequency head shake was done. The motive of such high frequency head shake is to generate the inertial forces that disengage the otoconia adherent to the cupula of the horizontal semicircular canal, though it causes severe vestibular symptoms and sometimes vomiting. That's why the person you see there is standing with a bucket. Verifying supine roll test, that is supine roll retest, was done. One hour later, and as you can see that sit to supine did not elicit any nystagmus, that was not present even during the initial retest. On head yaw to the right, the eyes are absolutely static. We maintained this position for full 1 minute. In horizontal semicircular canal BPPV, be it cupulolithiasis or canalolithiasis, the latency of nystagmus is not more than 5 to 6 seconds. So during retest, only half minute of observation is essential. On head yaw to the left, no nystagmus, eyes are absolutely static, and patient is free of vertigo. She continues to remain free of vertigo with only 1 minute of head shaking that was done once, no medications. She was tested again the very next day at 24 hours, and she did not had any oculomotor responses during the supine roll test. So in this patient, possibly the otocondylar debris was on the utricular side of the posterior cupula, and as the head was shaken side to side for 1 minute, it got engaged, it disengaged and got dissolved and got embedded into the utricular macula, and that's why there was an immediate relief in symptoms as well as disappearance of the oculomotor responses. Had it been on the canal side, it would have converted into the geotropic variant. Vestibular neuritis, there is a history of vertigo, dizziness, vomiting, acutely dizzy, non-positional, and you see a right beating nystagmus here, horizontal mostly, increases on gaze to right, and decreases on gaze to left, but the direction remains same. That is unidirectional right beating, and that is exactly the Alexander's law. The head impulse test, you have to do it multiple times unexpectedly. The patient should not be knowing. There you see a catch-up second, not to the right, but to the left. Nowadays, this entity is called acute unilateral vestibulopathy, left in this case. Earlier, it was called vestibular neuritis. Fukuda stepping test is also useful. In around 50% of the patients, the patient rotates to his involved side more than 45 degrees. But this is not very sensitive. In 25 patients, he may rotate to the non-involved side. This is again one of the other examples. Left vestibular neuritis. Right beating nystagmus increases on gaze to the right. This is grade 3 nystagmus. Beating increases on right gaze. It is still present in the gaze straight ahead, and on left gaze it is decreasing. Head impulse test to the right is negative. To the left you see a catch-up second. So it points to a hypofunctioning left membranous labyrinth, and in setting of acute vertigo it is likely to be because of acute unilateral vestibulopathy. However, a infarct in the left-sided root entry zone or demyelination can cause identical symptoms, because ultimately it is the fascicle which is involved. This is another patient of audiovestibular syndrome who had progressive hearing loss, and he had vertigo attack around 4 to 5 days back, and now he has come to me for evaluation of his illness. There was no spontaneous nystagmus. So what to do now? You need to know which is the hypofunctioning labyrinth at this time. So that can be done by high frequency head shaking side to side, 30 degrees excursion with 30 degree of neck flexion. And there you see a left beating horizontal nystagmus. His audiogram showed low frequency hearing loss of sensorineural type in the right ear, and he is a case of Ménière's disease. Vestibular paroxysmia was considered to be a entity which was described few years back. Episodes of vertigo lasting up to 1 minute, short lasting, sometimes there is unsteadiness with tinnitus. This is a person who was hyperventilated for a minute, and after 1 minute you see a nystagmus which is horizontal right beating. He had short lasting vertigo episodes with tinnitus and sometimes postural imbalance, 10 to 15 per day. What did I order? MRI brain with CIS imaging. CIS imaging means constructive interference in steady state sequence, and that shows a neurovascular cross compression which is displacing the vestibulocochlear nerve. So what happens that is that the vestibulocochlear nerve as it emerges out of the brainstem or enters the brainstem, the first 10 millimeter is of transitional myelin. So if there is a pulsatile structure crossing it, it would cause the damage of the myelin, which is a weak myelin akin to the, because it is akin to the central myelin, and because of that, the chronic myelin damage, there are apoptic discharges. Central nystagmus, there are 5 6 patterns which I am showing here one by one. Very important. This is the first pattern. Sherry malformations causing downbeat nystagmus, mainly in the lateral gaze. This is from the collection of the nanos, the library maintained by Daniel Gold and his team. There is a gaze evoked vertical downbeat nystagmus on lateral gaze to right as well as to the left. Vertical gaze evoked nystagmus, that is downbeating. In any case, most of the spontaneous downbeating nystagmus are to be taken as central nystagmus unless and until proved otherwise. My friend Andrea Casclusi has proved that it can occur from the posterior canal jam. The gaze evoked nystagmus is shown here. On left gaze, there is a left beating nystagmus, and as the patient shifts gaze to midline, that is straight ahead, there is a rebound nystagmus. It goes and again comes back to the left side. So, a gaze evoked nystagmus combined with the rebound nystagmus is a sure shot sign of a central nystagmus. It is important to note that the eye abduction should be just 60 to 70%, because you can make the endpoint nystagmus to emerge if you take the full abduction of the eye. So a direction changing gaze evoked nystagmus, which is right beating during the right gaze and left beating during the left gaze, is always central unless proven otherwise, and you cannot prove it otherwise. This is a rebound nystagmus. To the left, it is left beating, and as the eyes come to the central position, it will again drift back to the left. On right gaze, it is right beating. As the eyes are shifted to straight ahead gaze, it will again, there would be a nystagmus which is to the opposite side. That is called rebound nystagmus. This is the central paroxysmal positional nystagmus. Lying down, as the head is turned right, there is a nystagmus which is right beating, and on right head turn, it becomes left beating. That is the apogeotropic nystagmus. This is the periodic alternating nystagmus. It beats for many seconds in one direction. Then there is a pause. Then it starts beating in other direction. At present, it is left beating. Let us see what happens after some time. Now it is a period of pause. And now the nystagmus starts beating towards the patient's right, and this would go so on and so forth. And this is a highly localizing central nystagmus occurring because of the involvement of the velocity storage mechanisms, that is the nodulus and oblique or uvula. That is, it localizes to the posterior fossa. This is the sixth thing, which is called cross coupling. 48-year alcoholic, sudden imbalance, diffuse visual disturbances, not able to stand unaided, bilateral six cranial nerve palsies in the emergency department. With the fixation removed, direction changing gaze evoked nystagmus, which is horizontal. On left gaze, again there is a left beating nystagmus. Vertical nystagmus in frenzel goggles with lid on. You see a vertical upbeat nystagmus. Head shaking is done side to side, and now you see 1 to 2 beats of downbeat nystagmus. This is called perverted head shake nystagmus or cross coupling nystagmus, and this is a central nystagmus. So, six types of nystagmus I have told as labeled as the central vestibular nystagmus. This is downbeat nystagmus in little gaze. Gaze evoked nystagmus coupled with rebound nystagmus, central paroxysmal positional nystagmus, which is apogeotropic, periodic alternating nystagmus, and cross coupling nystagmus. This is a bidirectional gaze evoked nystagmus in this patient. Operated for Chiari malformations many years back. On right gaze, it is right beating. It indicates defective horizontal gaze holding structures. The involved are nucleus prepositus hypoglossus and medial vestibular nucleus. This is a patient with acute imbalance. Vomiting. He came to me with a MRI which was normal. As he is made to stand tandem, you can see that there is a truncal latropulsion. The patient is being pulled by unknown force to his left. He has to be supported from his left side by his son. His closed eyes are deviated to his left. As he opens, there is a refixation socket maintaining the straight ahead gaze. Closing, it deviates to his left. If you see such a patient, even with a normal MRI, it would be advisable to repeat a MRI after 48 to 72 hours. And in this case, we repeated a MRI after 48 hours. The earlier MRI done on 1.5 Tesla was negative. MRI showed left dorsolateral medullary infarct. This is again a child around 8 to 10 years old who developed gait difficulties. 16 March 2023. It looks like a gait which is ataxic as well as spastic. As you can see that there is a limbs, they cross each other, try to cross each other, but this is a dissociation, because if it is a spastic gait due to spasticity, there would not have been so much of the truncal ataxia. The problem with this child was that he was sent to a boarding school by his father and he didn't want to do that. He even fell down dramatically. There you see. He was given some form of cognitive behavioral therapy, and the next day he walks normally and he even runs. He was taken away from that school on my advice, and I told him that you have to behave properly like that. I told him to run a few steps, and he also ran.